And again, I want to welcome our speaker, Dr. Laura C. Collins, who is the Vice Chair of Anatomic Pathology and the Director of Breast Pathology at Beth Israel Deaconess Medical Center in Boston, Massachusetts, and a Professor of Pathology at Harvard Medical School. Dr. Collins graduated from Charing Cross and Westminster Medical School in London and completed her anatomic and clinical pathology residency and fellowship training at the Beth Israel Hospital in Boston. Dr. Collins is an internationally renowned breast pathologist. She has published numerous original articles, review articles, and book chapters on breast pathology. She has co-authored the Biopsy Interpretation of the Breast textbook, now in its third edition, and contributed several chapters in the WHO Tumors of the Breast series. She has served in numerous leadership roles, including president of the Arthur Purdy Stout Society of Surgical Pathologists and a member of the USCAP Board of Directors. Dr. Collins is a committed educator, giving numerous lectures and courses around the US and the world to support the ongoing education of pathologists and pathologists in training in the diagnosis of breast disease. And of course, with her commitment to education, she is now kindly providing this lecture today. And I will turn it over to you, Dr. Collins. Thank you again and welcome.
Thank you very much, Raul, Dr. Gonzalez. It's a pleasure to be here. All right, good morning, good afternoon, and good evening, everybody. It's a pleasure to be here today speaking about core needle biopsy of the breast and sort of contemporary common diagnostic challenges. So things that are more challenging for us in an era of neoadjuvant systemic therapy and how management has evolved also for benign breast lesions as well. So that is what I'm going to be spending time talking about today. Okay, now why am I not advancing? Oh, there we go. I have no disclosures. All right, so I'm going to spend a few minutes by way of introduction just talking about the importance of determining radiologic-pathologic correlation for the different types of lesions encountered. So masses, microcalcifications, and non-mass enhancing lesions. Just a couple of minutes on lesions easily overlooked because that can prevent the need for a second biopsy or an excision. And then I'm going to spend a good deal of time talking about common diagnostic dilemmas and the management impact today. And then the final pieces will be on cancers in the core needle, in an era of core needle biopsy with neoadjuvant systemic therapy. So radiologic pathologic correlation. So as you all know, I'm sure, the pathologic diagnosis on a core needle biopsy must be concordant with the impression from imaging studies. And any discordant diagnoses must be reconciled. And that may be either through repeat core biopsy or a surgical excision. And the best way to contend with these discordant diagnoses, or one of the easiest ways to do it rather, is through radiology pathology correlation conferences. And we host such conferences in our department once a week. And hopefully your institutions do the same also. And I think for the trainees on this listening in today, it's important to make sure you attend these sometime during your training, because I think it is very instructive in terms of what the challenges are for the radiologist, what they understand in our more descriptive reports, and just hearing the dialogue that goes on in terms of trying to reconcile cases for patients. It's important as the pathologist to know the clinical history and imaging findings, including the radiologist's differential diagnosis. So it's also helpful in terms of core needle biopsies for microcalcifications that for the radiologist to perform a specimen radiograph. In fact, I think it's really imperative that they do that so that they can confirm that they have obtained the microcalcifications. It's helpful if they then separate out the core biopsies with from those without the calcifications and submit them separately. The reason for that is that if you don't see the calcs on the first few levels, you can simply level the blocks that are supposed to have the calcifications and not necessarily, you don't need to level the other blocks then. That saves resources and time. It's very helpful to have access to the specimen radiograph, either as a, an X-ray submitted with the specimen or at least digital access to see. And the reason for that is that the calcifications you see on the slide must correlate with those seen on the specimen radiograph. And so I find, you know, sometimes you'll see these teeny tiny calcifications as indicated here. Those rarely are the correlate for image detected calcifications. These are far too small to be seen on most imaging studies. So if you actually look at the X-ray and see how the calcifications are clustered, and you know what sort of size they are, that can help you decide if what you're seeing under the microscope is a good correlate. And if it isn't, then it's important that you obtain additional levels. If there are a lot of blocks that are supposed to have calcs and I don't see any calcifications, then what I tend to do is actually X-ray the tissue blocks and just do levels on the tissue blocks that still are supposed to have the calcifications. If you don't see the calcifications, what can you do? I already mentioned obtaining additional levels. That's important. As I said, if there are a lot of blocks that are supposed to have them, I usually X-ray the blocks first and then just do levels on those that have the calcs. You can also look for holes or tears in the tissue. Sometimes the histotechnologist, as they're cutting the section, the calcification kind of pulls through the tissue and pops out. And then of course, calcium oxalate crystals, look in apocrine cysts because that's usually where these hang out. And you can polarize or lower the condenser on your microscope and you'll see these, they'll turn from translucent to brightly polarizable crystals. Here's what I mean by clues to the fact that there were calcifications in the tissue and they've been pulled through. You see this line here going through the tissue. That is due to the calcification that was likely sitting right here, being pulled through when the histotechnologist cut the section, and it usually pops out. So thinking about examples of discordance, it's important to ensure that the pathology correlates. So if the radiologist tells you that they see a spiculated mass on mammogram, and you just have benign findings such as sclerosing adenosis or usual ductal hyperplasia, that usually is not a good correlate for a spiculated mass. Perhaps with the exception of a radial scar or complex sclerosing lesions, because those do have kind of a stellate appearance, although they, radiologists will tell you, breast images will tell you that they tend to have sort of a translucent kind of core that correlates with the center of the radial scar. So there are distinctive features, but that sometimes can be a correlate for a spiculated mass, but you just want to be careful about that one. Circumscribed mass, that would be something like a fibroadenoma. Mucinous carcinomas can also look like circumscribed masses. Again, if you have a non-specific kind of finding, that is not a correlate for a circumscribed mass. And then if they have said that they're worried about the calcifications, they're suspicious or malignant looking, any benign diagnosis, even if there are associated microcalcifications, should be considered discordant until you've had time to discuss it and go over the case with the radiologist. There are some cases that remain rather nebulous with regard to concordance, and these include non-mass-like enhancement on MRI. We don't really have a great handle on the pathologic correlates for this, although I will say the data are coming out on this topic. It's just that they're rather broad in terms of what the correlates are. So there are 3 studies on this of which I'm aware, and all 3 show that about 2/3 to 3/4 of cases of non-mass enhancing lesions detected on MRI are benign on pathology, and the pathology includes patch, pseudoangiomatous stromal hyperplasia, UDH, sometimes apocrine cysts or sclerosing adenosis in the majority of those benign cases. About 10 to 15% will be atypias, and then about 15 to 20% will be malignancy, including DCIS and invasive carcinomas. The challenge is that the benign and malignant lesions often share similar morphologic characteristics, necessitating then biopsy to try and distinguish or determine with confidence what the pathology is for the imaging finding. And then other sort of more nebulous things, vague masses or developing densities on imaging, that can sometimes be just breast tissue or vaguely fibrotic breast tissue with no discrete mass forming lesion on core biopsy. Sometimes we'll have cases where, you know, when the radiologists are reviewing it, they say, well, you know, maybe it's just a sort of nodule of breast parenchyma. And you can sometimes even see that on the core biopsy where the sort of fibrous breast parenchyma seems to stand out from the fatty background. And again, this requires kind of a conversation with the radiologist to make sure that it is a good correlate and that they weren't particularly worried about it. I'm always slightly anxious that if they're worried enough to biopsy it, I feel like it should be something more than just normal breast parenchyma. But you know, I think a conversation is what's needed in those types of situations. And then sometimes PASH can be a correlate for a vague mass or developing density on imaging studies, as illustrated in this image here. You can see that there is some pseudoangiomatous stromal hyperplasia here. You have to be careful about PASH on core biopsy because it is present, or it is found in about 25% of all benign breast biopsies. So the fact that you have it doesn't mean that it is the correlate for the imaging findings. So if it's focal and subtle and doesn't really look like the target lesion, you want to be careful not to overplay its presence. And if I have something just like as depicted in this image here, I would tend to put a note saying that there's no definitive evidence of a mass forming lesion in a case like this. And then we would have to go back, we would discuss it in the RadPath correlation conference and take it from there. A couple of minutes on lesions easily overlooked. And the reason to talk about these is that if you don't make the observation that these are important and potentially the correlate for a mass or non-mass enhancing lesion, the patient, as I said, may require an additional biopsy, additional follow-up, or even an excision to try and determine what the pathologic correlate is for their imaging findings. So, you know, benign apocrine cysts, sometimes we just think, oh, these are benign cysts, they're not of any importance, but when they're clustered together like this, they can be the correlate for an ultrasound detected breast mass, for example, or non-mass enhancing lesions sometimes correlate with apocrine cysts. And then cyst walls can be quite subtle as well. They can just look like bland breast parenchyma without any kind of striking features. But if you pay attention to the edges of the tissue, you may appreciate that there's sort of a little condensation of the fibrous tissue around the edge of the core biopsy. And sometimes you'll see attenuated epithelium running along the edge. It sort of sloughs off in some cases or gets rubbed off in some cases. But pay attention to that because that could be the correlate of a mass forming lesion. And again, you might just want to be descriptive and not definitive about that, but I think you can certainly say it's suggestive of a cyst wall. And if they thought it was benign and a cyst, then you can both be satisfied that you have the correlate for the image finding and nothing more is required. Here's a nice example of what I was talking about a few minutes ago about breast parenchyma being sort of the correlate for a non-mass enhancing lesion or subtle masses. So here we just have a focus of usual ductal hyperplasia, a little bit of apocrine metaplasia. Now UDH in and of itself is not really meant to be or is not thought of as an imaging target. But as I showed you in that data from the non-mass enhancing lesion studies, sometimes it is the correlate in MRI detected lesions. And you can see how that might be. Here we have just a little nodule of UDH and it's standing out from the background fatty parenchyma. And I would be fairly confident that this would be the correlate for a small, 4 millimeter lesion that they may have found on an imaging study, especially if they're confident that they've hit the target and it stands out from the background fat. Here's another core biopsy of an entity that can be easily overlooked. You can see it looks just like normal breast parenchyma at first blush, But notice how the stroma here looks a little bit funny. Sometimes I think it looks kind of waxy. Also, something else to notice is the presence of lymphocytes here, tightly clustered around the terminal duct lobular units and maybe the vascular spaces. You know, lymphocytes we don't really pay attention to, I think, or inflammatory cells when there are just few and far between in the breast. You don't particularly pay attention to them, but this is a case where, or this is an entity in which they are of importance. This is an example of lymphocytic mastopathy. And again, as I said, on low power scanning magnification, you may think this just looks like normal breast tissue, but you need to notice this unusual change to the stroma and the clusters of lymphocytes around the ducts and lobules and vessels. And so here are the lymphocytes. And then here's a higher power image of a case of lymphocytic mastopathy. And as well as the keloidal collagen or the unusual change to the collagen, one is also supposed to see epithelioid myofibroblasts, which are nicely appreciated in this particular case here. So that constellation of those three features should be enough for you to at least describe the finding and suggest this is a possibility for the diagnosis. Now, this used to be called diabetic mastopathy because of its association with type 1 diabetes. It's also associated with other autoimmune type phenomena. And it can also just be sort of independent of any of these entities, and you don't always have a history of some sort of autoimmune disease or diabetes. So hence, it's now being called lymphocytic mastopathy. Just some pointers on how to avoid getting yourself in trouble. I would always, as I've emphasized, be aware of the imaging findings in the radiologist's differential diagnosis. I think it's useful to be quite liberal in your use of levels. If you think, if you don't have a mass, then you need to get levels. You always should get levels if you don't have a mass. You should always get levels if you don't see the calcifications. If you have something atypical looking, it's good to get levels. I would be judicious in my use of immunostains. I think you can get yourself in trouble here by doing more rather than less. And we'll talk about immunostains in the next section. And then you want to be conservative. Avoid overdiagnosis when the findings are equivocal. You don't want to be cavalier with limited tissue provided by core needle biopsy, because that can get you into trouble with regard to next management steps. And we'll talk about that a little bit more in a few minutes as well. And then in the final part of the talk, I'll talk about the importance of re-reviewing triple negative breast cancers at the time of sign out of ER, PR, and HER2. So common diagnostic dilemmas and the management impact. So I think for me, the commonly encountered diagnostic dilemmas are UDH versus intermediate nuclear grade DCIS, ADH versus low grade DCIS, DCIS versus LCIS, and here we're talking about particularly non-classical variants, benign sclerosing lesions versus invasive carcinomas, and then papillary proliferations can be a challenge, but I'm not going to be including that topic in this presentation today. So UDH versus DCIS, things to think about. Well, as I said, the differential diagnosis is most often with intermediate nuclear grade DCIS. It's not UDH versus ADH. It's not UDH versus low grade DCIS that are challenging. It's UDH versus intermediate grade DCIS. The micropapillary pattern of UDH can also be a bit of a challenge in distinction from DCIS as well. And then consider the imaging target. I said just a few minutes ago that usual ductal hyperplasia doesn't typically have an imaging correlate unless it's involving some sort of benign sclerosing lesion. DCIS, on the other hand, is often associated with microcalcifications. It's often an imaging, an MRI enhancing lesion. And so it is far more frequently the imaging target than usual ductal hyperplasia is. And then in problematic cases, immunohistochemistry can be useful. So here's a core biopsy of an epithelial proliferation. And I think this sort of thing is the kind of case that gets me worried that I might be dealing with intermediate grade DCIS. We've got lots of spaces filled with an epithelial proliferation. It looks like the spaces are slit-like, which would favor it being usual ductal hyperplasia, but there's a lot going on here. And so that tends to make me a little bit anxious. You might also worry whether this looks a little bit like necrosis. I think it's probably secretion, but sometimes UDH can have necrosis, and of course DCIS can have necrosis. But look at the epithelial proliferation here. We've got slit-like spaces, we've got intranuclear inclusions. There's variability in the size and shape of the nuclei. Some are dark and smaller, some are larger and have paler chromatin. And there's a lot of heterogeneity here. Preferential location of the slit-like spaces or the spaces at the periphery of the duct involved would also favor usual ductal hyperplasia. Here, just a higher power showing you the heterogeneity of the nuclei and the intranuclear inclusions. Sometimes you can see grooves as well. I don't see a nice one to highlight here, maybe something there, but this particular case doesn't have striking nuclear grooves. So the key features of usual ductal hyperplasia, as I said, are that it's composed of a heterogeneous cell population that the cells vary in size, shape, and orientation. And the cell borders are poorly defined. So it's sort of more like a syncytium of cells rather than discrete, individually appreciated cells. And there's variation in size, shape, and placement of the nuclei, as well as them being overlapping also, nuclear grooves and inclusions I mentioned. Architecturally, UDH can be solid, it can have fenestrations or slit-like spaces, and it can be micropapillary in architecture. The lumens are irregular, variably sized, and vary in shape. They're more often slit-like and polarized and displaced to the periphery, and there is an absence of polarization of the cells around these lumens. With regard to adjunctive immunohistochemistry, usual ductal hyperplasia is composed of a mixed population of cells, as I just described. So those cells express both low and high molecular weight keratins. So some express low, some express high. And these are often in a heterogeneous or mosaic pattern. DCIS, on the other hand, is a monoclonal population of cells that expresses low but not high molecular weight keratins. And many of you may use the triple stain at your institution, in which the P63 stains the myoepithelial, the nuclei of the myoepithelial cells. There is a high molecular weight keratin that stains the cytoplasm of epithelial and myoepithelial cells brown. And there's a low molecular weight keratin here that stains the epithelial cells red. So you can see that this is a heterogeneous cell population, and as such, you can diagnose it as usual ductal hyperplasia. We tend to use just CK56 rather than that combination stain, because I don't think you really need the P63 in that instance, and really the high molecular weight keratin is what you're needing to help you here. So we do CK56, and that will show a heterogeneous pattern of expression, as you see in this image here. And then ER is the other stain that I think is helpful. Again, UDH is a mixed population of cells, so you'll see heterogeneous expression of ER. DCIS is monoclonal, and so those cells show strong diffuse expression of ER. The exception here is that some high-grade DCIS may be ER negative, but that's not usually a differential diagnostic dilemma. It's much easier to recognize high-grade DCIS and make that distinction from usual ductal hyperplasia. So I don't think that would be a pitfall here. Here's what ER staining looks like in usual ductal hyperplasia. This is what I mean by heterogeneous. You have some nuclei that are staining strongly, and that is dark. You have others that are less strongly stained, and others yet that are negative. So this is what we mean by a heterogeneous pattern of expression of ER in usual ductal hyperplasia. What are potential pitfalls? I mentioned one of them already. The presence of necrosis can lead to misinterpretation as DCIS. What you should do here is just kind of subtract the necrosis mentally. So imagine the proliferation without the necrosis, and then look at the epithelium. Are the features those of usual ductal hyperplasia or DCIS? And then involvement of benign sclerosing lesions by usual ductal hyperplasia can lead to misinterpretation as either DCIS or even invasive ductal carcinoma. And here what you want to do is evaluate the stroma. Is the stroma pink and fibrotic? If so, that favors it being a benign sclerosing lesion as the underlying entity. That's not to say that invasive carcinomas can't have pink fibrotic stroma, but more often they have kind of more of a desmoplastic bluish stroma than a pink fibrotic stroma. And then you would use immunohistochemistry against myoepithelial cells if necessary, but here you want to interpret carefully, and I'll talk about that in just a second. Here's an older case that we received in consultation. The patient had been diagnosed with invasive ductal carcinoma, and she was coming in actually for management. So this case hadn't been sent in consultation by the pathologist, but upon review, we questioned the diagnosis. So look here, you've got very pink fibrotic stroma. I will acknowledge that it is a little cellular here at the periphery, but the pink fibrosis always gives me pause and makes me wonder about whether I might be dealing with a benign sclerosing lesion, at least as the underlying entity. And then when you go on higher power, actually you can see, I think even on H&E quite nicely, the myoepithelial cell layer, or at least what looks like a myoepithelial cell layer. I think what may have been disturbing is the presence of necrosis here, the florid nature of the epithelial proliferation, the irregular contour of the nests may have been what prompted the pathologist to think about invasive carcinoma. The pathologist actually did do a myoepithelial cell stain. Here you can see P63, but the absence of staining in some areas still sort of channeled the pathologist to think about this being an invasive carcinoma. Well, that is a pitfall because, well, first of all, the nuclei of myoepithelial cells may not be in the plane of section, so that's why you might have some absence of staining in some areas. And also there can be reduced expression of myoepithelial cells in benign sclerosing lesions, and I'll show you the paper on that in just a second. But a red flag should have been raised when the ER stain was interpreted, because look at the heterogeneity here. Low and intermediate grade DCIS and grade 1 and grade 2 invasive ductal carcinomas should have strong diffuse staining with ER. It would be very unusual for them to have this kind of moderate heterogeneous pattern of staining here. So that's a red flag that you might be dealing with usual ductal hyperplasia. And any case in which you see that, it's a useful safety check to go back, reevaluate the H&E, do stains if necessary to help figure out whether it's actually UDH or a malignant lesion. Here's another example. This case, I think, is sort of illustrates the challenge of separating UDH from DCIS. I think this looks quite similar to that first case that I showed. You've got sort of streaming of the epithelial cells here, lots of nests filled with this same epithelium. We've got spaces, some are more slit-like and don't appear to have good polarization of the epithelial cells around them. Some maybe do have a little bit of polarization. On higher power, yes, maybe some polarization, but a lot of heterogeneity to how the, to the side, excuse me one second. A lot of heterogeneity in the size and shape of the nuclei. So that would make you think about usual ductal hyperplasia, I think, or you should at least consider it. What makes me think about DCIS in this case is the presence of a lot of apoptotic debris. When you see lots of apoptosis or nuclear mitotic activity, that's sort of unusual in usual ductal hyperplasia. So that would make me do immunostains if I wasn't confident about this being DCIS. Here, I think this polarization also makes me think about DCIS. And then the other thing is that the nuclei, while they vary in shape and placement with respect to one another, actually, I think the chromatin pattern of intermediate grade DCIS, the nuclei look very similar one to another. And so that I find is quite a helpful feature. Nonetheless, CK56 was done to help sort this out. It's a little bit of a dirty stain, but you can see it's staining the myoepithelial cells and not the epithelial cells. And here is what ER should look like in intermediate grade DCIS. So all the cells are staining, it's strongly diffusely positive. And there are significant management impacts to an erroneous diagnosis of this on core needle biopsy, because for DCIS, you would have the patient goes on to excision. She may elect mastectomy depending on the extent of disease. And patients are increasingly opting for bilateral mastectomy for diagnosis of DCIS rendered on core needle biopsy. So you want to be really confident that you're dealing with DCIS. Whereas usual ductal hyperplasia, the patients don't require any further management. What about ADH versus low-grade DCIS? Well, ADH is defined in terms of its resemblance to low-grade DCIS. And a diagnosis of ADH should not be made unless you really are seriously considering low-grade DCIS. So that gets back to that point I was making a few minutes ago. It's not UDH, it's not the sort of, is this UDH, is it ADH kind of thing, because that is not morphologic. Those are not morphologically similar. So you shouldn't even be making a diagnosis of ADH unless you're really thinking about low-grade DCIS. And then on core biopsy, I would advise that a diagnosis of low-grade DCIS not be rendered unless the findings are unequivocal. Again, the reason for this is that patients are increasingly opting for mastectomy as a therapeutic strategy following diagnosis of DCIS on core needle biopsy. There are criteria to help us separate ADH from low-grade DCIS, but the thresholds are arbitrary. The criteria were developed in excisional biopsies. And so the WHO editorial board expert panel recommends a conservative approach when lesions of limited extent are identified, especially in core needle biopsies. So better to call it ADH or severely atypical intraductal proliferative lesion, and then you can definitively categorize the lesion when you have the excision specimen to evaluate. And because ADH, well, sort of this low-grade atypia really covers the spectrum from flat epithelial atypia through to low-grade DCIS, deciding whether to kind of draw those cut points can be very challenging. And we see this in diagnostic agreement rates for ADH being very poor, actually, between 40 to 60%, compared to lesions at either end of the diagnostic spectrum. So there's really excellent agreement by pathologists on benign lesions and really excellent agreement on invasive lesions. But for these lesions, these borderline lesions, it's much more challenging for us all to agree. And the variability is related to differences in professional opinion and diagnostic thresholds and clinical practice, frankly. Depending on what the surgeons do, some pathologists may sort of scale their interpretation based on that. Certainly in Europe, excision is not performed for ADH. So if they really want an excision, they have to call it low-grade DCIS. Whereas here, we are more inclined to call something ADH, knowing that it will have an excision, and we can wait to call it DCIS on the excision specimen if the criteria are met. And then sharing the case with somebody else, getting consensus, and then use of immunohistochemistry has been shown to improve diagnostic agreement. I'm not really sure what IHC you could use, because there are no IHC that will help separate ADH from low-grade DCIS. So just some examples to illustrate atypical ductal hyperplasia. So here are two spaces, but it's very limited in extent. So obviously one should call that atypical ductal hyperplasia, but it has all the qualitative features of low-grade DCIS, being round, monomorphic proliferation, polarization around these spaces, and completely filling the space. Here's another example where we have multiple spaces filled with the same monomorphic proliferation with polarization of the epithelial cells around these cribriform spaces. But again, very limited in extent, so you should just call it atypical ductal hyperplasia. Oh, and here, by the way, is what we would call flat epithelial atypia, right? There's no architectural atypia in this space here, or even in this space here. So FEA combined with ADH here. Here's a case that actually was called low-grade DCIS on core needle biopsy. The patient did go on to have a mastectomy performed, and there was no additional findings. So this is, this is sort of a cautionary tale. We've got very limited disease here, just 2 millimeters in extent, and it's very kind of sloughed and poorly perhaps poorly fixed. And you might even argue that it's not completely filling the spaces, right? So on this side here, it's flat. It is cribriforming over here, but to my mind, this is only sufficient for a diagnosis of ADH. So the WHO guide suggests that we evaluate the cytologic features, then the architectural features, and then the extent to help us decide whether we're dealing with ADH or low-grade DCIS. And again, the management impact is can be different, right? So for DCIS, as I mentioned, patients may elect for sort of a very definitive procedure even after a core needle biopsy diagnosis, whereas ADH usually prompts surgical excision only, although some institutions are doing sort of a very comprehensive radiologic-pathologic correlation, and if the ADH is very limited and the calcifications are entirely removed, some institutions are observing those patients. It's important to note that there are clinical trials going on for low and intermediate grade DCIS that are observation only. So paradoxically, actually, if you call it ADH, the patient would have an excision, but if she's enrolled in one of these trials and she has low-grade DCIS, she may not get an excision. So there's a little bit of a paradox there. But I think in the US, the COMET trial may be expanding to include atypical ductal hyperplasia now as well. DCIS versus LCIS here points to consider that the differential is most often with non-classical variants of LCIS, that is pleomorphic LCIS or LCIS with florid LCIS with necrosis. Consider the imaging target. Again, DCIS is usually associated with calcifications. Here we can use immunohistochemistry, E-cadherin, P120-catenin, and beta-catenin can be helpful. Just remember that E-cadherin can show aberrant expression in LCIS. So just because it's positive doesn't make it DCIS. So you need to be careful about that. But since both DCIS and non-classical LCIS require excision, if you are uncertain, you could potentially sign it out as carcinoma in situ and defer to excision for definitive categorization, although I don't encourage that practice. So here's a nice example of classical LCIS. You've got a monomorphic proliferation of atypical epithelial cells. You can see small intracytoplasmic vacuoles, so easily recognizable as LCIS. Here's a very similar looking proliferation, a small monomorphic atypical epithelial cells. But here we have maybe a hint of polarization and better seen up here, almost off the edge of the screen. And so this is actually DCIS. There was greater extent of this. DCIS, not LCIS, or at least a ductal proliferation, not an atypical lobular proliferation. So those are sort of subtle features that can help you separate out DCIS from LCIS. Potential pitfall is LCIS involving collagenous spherulosis. So it looks like it's cribriforming, but these are actually myoepithelial cells here. And so it's LCIS involving collagenous spherulosis. Here's what I mean by florid LCIS. So here you have spaces greatly expanded by an atypical epithelial proliferation. There's central necrosis and calcification. So you see what the imaging target was here. But when you look on high power, interestingly, these are very monomorphic epithelial cells. Usually for comedopattern DCIS, you expect to see high-grade DCIS. And then if you look closer, you can see that there are intracytoplasmic vacuoles, maybe some signet ring cell features. And so it prompts consideration that this might actually be florid LCIS and not DCIS. So here we did E-cadherin. You can see that it's negative for E-cadherin with good internal control. And P120-catenin shows cytoplasmic expression with good internal control, showing membranous expression here. Here's another example of such a case where you can see that there is central necrosis and calcification, but really rather a monomorphic proliferation. And the P120-catenin here shows nice cytoplasmic expression with good internal control. So E-cadherin is a membranous stain in DCIS and normal epithelium, whereas it typically is absent in LCIS. But as I said, it can show aberrant expression, and I refer you to articles on that topic if you're interested. This table just shows how these different immunostains stain in normal epithelium and DCIS. So they all three show a membranous pattern of expression in those two entities. Whereas in LCIS, E-cadherin shows absence of membrane staining, as well as beta-catenin shows a similar absence of staining, and P120 shows cytoplasmic staining. So it's a nice positive stain to use if your lab has that stain. Management impact, excision or mastectomy for DCIS. No further management for incidental classical LCIS. Now, I didn't really talk about that, but there would be no management if it's incidental to the target lesion, as long as that doesn't require excision. Non-classical LCIS still does require excision, and LCIS that's the imaging target. So even classical LCIS associated with calcifications should really be excised also. Benign sclerosing lesions versus invasive carcinoma. Points to consider here are lobular centricity. So when there is lobular centricity, you want to think about benign. Invasive carcinomas should have more of an infiltrative border. The myoepithelial cell layer obviously would be important. Hyalinized or fibrotic stroma I mentioned. Be careful about carcinoma in situ involving complex sclerosing lesions or radial scars. And again, use myoepithelial cell markers if necessary. So here's a nice example of a radial scar. You can see that sort of hyalinized stroma in the center and the epithelial elements radiating out. LCIS and adenosis. This is a case I had not too long ago where the nests, you know, I mean, they were kind of haphazardly arrayed in the breast core biopsy here. And obviously you can see that there's this monomorphic proliferation here. I wondered about LCIS and adenosis. I definitely thought that that's what it could be, but it was difficult to appreciate the myoepithelial cells here. And it wasn't brilliantly lobulocentric. You know, I could talk myself into it being lobulocentric, but I could also talk myself into it being a little haphazard and infiltrative. So this is the sort of case where you'd want to do myoepithelial cell markers to help reassure you that you're dealing with LCIS and adenosis. Another case here, this actually was called invasive carcinoma. Look at the fibrotic stroma here. There's a lot of kind of sclerosis, and certainly there's atypia here, there's DCIS here. And then these small nests here that you wonder whether they might represent invasive carcinoma. It looks like there might be a basement membrane and maybe myoepithelial cells here, but difficult to be confident, and certainly a large degree of atypia. The myoepithelial cell stains were positive, so one could be reassured that you're dealing with DCIS in a complex sclerosing lesion. That still needs excision, of course, but not sentinel lymph node biopsy. Here's the data on reduced myoepithelial cell marker expression in some benign lesions. We showed this in a study some years ago now where there was reduction in expression of CK56 and smooth muscle myosin heavy chain in some cases with normal expression using other markers. So just beware of that pitfall. Make sure you use more than one marker and interpret with the H&E in mind as well. Management impact for complex sclerosing lesions. Usually those are still excised, but there is evolution with regard to this. Some small radial scars are not necessarily being excised, whereas obviously invasive carcinomas need to be excised. In the presence of radiologic-pathologic correlation and in the absence of clinical concerns, there are several benign lesions or even atypical lesions that are no longer undergoing routine excision. And these include incidental ALH or LCIS, small asymptomatic papillomas, mucocele-like lesions without atypia. I mentioned small radial scars or incidental radial scars and columnar cell lesions. So it used to be that all of these were excised, but we're now seeing this evolve such that fewer excisions are being performed for these lesions. And this is because upgrade rates to carcinoma are going down with better RAD-path correlation. And so the threshold, you know, to excise is changing. ADH still has a high upgrade rate of about 20% to DCIS or invasive carcinomas, so those still should be excised. And you can see that in the radiology literature. Here is a pie chart showing how different centers are managing benign papillomas. Now, a decade ago, it would have been that everybody excised them, but now you see that 40% are excising, but between 10 to 20% of institutions are doing different things, either short interval follow-up, return to screening, depends on symptomatology and things like that. Moving now then in the last 10 minutes or so, just talking about cancers on core needle biopsy in an era of neoadjuvant systemic therapy. In this day and age, it's particularly prudent to review the H&E slide at the time of receptor sign-out, especially for triple negative cancers. You want to confirm that the morphology is consistent with breast carcinoma, check that there's no prior history of another carcinoma, and consider further workup if their findings are atypical or in the setting of a history of cancer. So some examples, hopefully not to scare you too much, but to show you how important it is to think about this. Here is a mastectomy specimen from a patient who had neoadjuvant systemic therapy following a diagnosis of triple negative breast cancer. And what you can see is sheets of malignant looking tumor cells. There are zones of necrosis here. You can see these are very high grade. I can easily see how this was called a grade 3 invasive ductal carcinoma, ER, PR, and HER2 negative. It looks just like one. The pathologist who had the mastectomy, however, noticed that there really was no kind of response to neoadjuvant therapy, and you would expect a pretty good response to with triple negative cancers. And he or she ascertained that there was a prior history of a different cancer. Also noted that there were some areas that looked a little different on the excision specimen or mastectomy specimen. There's a little bit of sort of maybe spindling of the cells here. And so they did an additional stain. I'll give you a moment to think about what that might be. And here we have a melan A stain. This was a patient with metastatic melanoma and not triple negative breast cancer. But you can see how easily one might have fallen or might have made that diagnosis in this particular case. I myself might very easily have done that. And so just stressing the importance of considering the patient's prior history. So don't forget that not all cancers in the breast are breast cancer. Consider this when the morphology is atypical. If there's an absent in situ component with caveats. Now here I mean, well, on a core biopsy of a big cancer, you may not have DCIS. Triple negative cancers, breast cancers are well known for having very little DCIS, so that's another kind of caveat there. But you know, it bears thinking about. And then of course, if there's a history of another cancer, and if the cancer is triple negative, you want to think about it. What malignancies are metastatic to the breast? Well, common ones are melanoma, ovarian carcinoma, lung carcinoma, and lymphoma. These are very rare, being reported to be about 0.2 to 2% of cases. And here, just to show you how similar triple negative breast cancer looks to metastatic melanoma or even other cancers, here is a triple negative breast cancer that I think looks quite similar to the melanoma I just showed you. Here's another type of metastasis, which looks very similar to the preceding slide. This is actually metastatic colon cancer, and again, would be very difficult without establishing the prior history. Here's a case that I think it's not a similar in the sense that it doesn't look like a triple negative breast cancer, but it looks very like a breast cancer. You've got atypical looking epithelial cells infiltrating through the stroma. Here are the benign ducts and lobules around. I think this is very compatible with an invasive ductal carcinoma grade 2. We did have the prior history in this particular case. Here's napsin A and TTF1, and here is the ER. Now, if one had inadvertently called it invasive ductal carcinoma grade 2, this ER stain should be a check for you that it may not be breast cancer, because as I said, when you have heterogeneous expression, that is something to be aware of. As far as breast versus lung, be aware that lung cancers may show focal ER expression, as I just illustrated. Also, some lung cancers can be GCDFP positive, and ironically or problematically, these are the ones that are usually TTF1 negative. And then some breast cancers can be TTF1 positive. So you want to be very careful when you're interpreting small biopsies, either from the breast or from the lung. I already mentioned this, heterogeneous expression of ER being a clue to the fact that you may not be dealing with breast cancer. And then here's another example. This was actually an intraparenchymal, breast intraparenchymal lymph node that had this glandular proliferation within it with calcifications. This is why it was detected. There was sort of calcifications with a mass. The patient had no prior history of anything, but we thought it looked a little bit funny. It didn't really look like breast. And it didn't really look that malignant, frankly, but it transpired that this was the first presentation of metastatic serous carcinoma. Here's the WT1 and PAX8 stain in this intraparenchymal lymph node. It was GATA3 negative. So be mindful of unusual looking tumors and triple negative breast cancers. I'm not saying that you need to work up every single case to rule out metastasis, but just give pause, check the history, and make sure that it's compatible with breast. Because you don't get that second chance with, with the excision specimen in an era of neoadjuvant therapy. The patient's going to go on and get her therapy without you having a chance to double check at the time of excision. And then the other thing you want to do is ensure that receptor status is concordant with histology. So ER low positive tumors are usually high grade. You should also be accurate with your percent positivity. Most of us are not using image analysis. We're sort of eyeballing it. But at that sort of low end of the threshold, so the 0 to 10%, it's important to be accurate. You don't want to overcall it, and you don't want to classify it as negative if there's some possibility. Patients who are at that low end of the spectrum, if you call them positive, you may unintentionally exclude them from triple negative therapies or trials, although I will say that many trials have now raised the threshold from less than 1% to less than 10%. So we have a little wiggle room there. And then you want to ensure that low-grade tumors are strongly and diffusely positive. So here's an example to illustrate that point. I sort of debated when I was preparing this talk, does this example go here, or does it go in the prior section that I was just talking about? So here, this is a case, it was called invasive ductal carcinoma grade 2. It looks like it could well be invasive ductal carcinoma grade 2. There's sort of this funny looking stroma here and these kind of fairly monomorphic cells. It was the reason I had the ER, PR, and HER2, and the ER expression was heterogeneous. So that, made me look at the H&E stain with, renewed intensity. And you should always do your colleagues a favor here, because the person who's signing out the ER, PR, and HER2 is not always the person who signed out the H&E, and that was the case here. It came from one of our affiliates. It was a 75-year-old with a large palpable breast mass. And you see on low power, actually, that it looks like a very circumscribed lesion. And now, maybe this is more of a myxoidy looking stroma. And here on high power, you can see, well, maybe it's some sort of benign thing and not actually invasive carcinoma at all. Here's the high power again. This is the ER stain. So again, ER is discordant with the sign out of a grade 2 invasive ductal carcinoma. So either we need to repeat the ER stain, or we need to check on our H&E. Obviously, I would check on the H&E first. And this is actually an example of an adenomyoepithelioma. It was excised, and here it is, and you can see the P63 stain over here. Also be careful about HER2 2+ versus 3+ staining. FISH is not mandated for IHC 3+ tumors. So if you overcall something as 3+, when it's actually equivocal, the patient may be sort of shunted down a pathway of chemotherapy and Herceptin, where really it may be 2+ and FISH non-amplified. So you need to be careful. Patients with palpable HER2 overexpressing tumors are candidates for chemotherapy, whereas ER-positive, HER2-negative patients may not be. So again, you want to ensure the morphology is compatible with HER2 positivity. So apocrine histology, that would go with HER2 amplification or positivity, abundant eosinophilic cytoplasm, and high-grade nuclei. So review and consider further IHC workup. As I said, if the findings are unusual, if the receptor status is discordant in the setting of a history of cancer, you want to reconsider the possibility of another disease. So to summarize, we reviewed how core needle biopsy diagnosis guides next management steps in radiology, surgery, and oncology today, and how it's evolved from years past. We've discussed how to best differentiate commonly encountered diagnostic challenges in breast core needle biopsy. And I've discussed the importance of considering non-breast primaries and the need for accurate reporting of breast biomarker studies in the era of neoadjuvant systemic therapy. And with that, I will say thank you for your attention. I hope you enjoyed it, and I can take any questions that Dr. Gonzalez has for us.
Thank you very much, Dr. Collins. That was an excellent lecture. We really appreciate it. We very quickly hit our cap of 300 attendees, and they listen with rapt attention. I've only received one question in the chat so far, which I'll read off, and then if anyone else has additional questions, feel free to post them in the chat, and Dr. Collins will answer them time permitting. The question we have, what are your parameters to distinguish apocrine ADH versus DCIS without necrosis, for example, in a big radial scar?
Oh, that's always very tricky. So I think, so if we're talking about core needle biopsy, I think it's a little bit easier because you can see, you can constrain yourself to just calling it atypical. You don't have to go all the way to DCIS, as I sort of was stressing. You can categorize it as atypical, and you will receive the excision, and then you can decide. I think with apocrine lesion, apocrine atypia, you really need to have the architectural atypia to help you there. So you want to have some spaces that have, you know, good cribriforming architecture. That can be helpful. If you have high-grade apocrine DCIS, obviously that you would just call high-grade DCIS. It's really, if you're asking about ADH versus DCIS, then you're obviously talking about the low-grade end of the spectrum. And as I said, I would be more circumspect in the setting of a core needle biopsy, and I would simply categorize it as, you know, atypical apocrine proliferation involving a benign sclerosing lesion, and recommend excision.
Thank you. I've received one additional question so far. Actually, another one just came up. So the one I have, if you are not reporting ER with image analysis, how many tumor cells do you recommend counting for ER reporting?
Well, so usually we don't have to count because the vast majority are strongly ER positive, right? So we just say greater than 95%. And then the others are negative, and so that's easy. So for that sort of few percentage, like, you know, 5 to 10% that are at the low end of the spectrum, then, you know, I mean, what I do is sort of look in several fields and do a guesstimate of the field, you know, how many in that field of cells, you know, what proportion in that field of cells is positive. And, you know, I would give a sort of between 5 to 10% or 10 to 20%. You know, I still do it as an estimate.
Thank you. A couple more questions have come in. The first one, this was not covered, but I recently had a TCCRP diagnosis confirmed at a BID affiliated institution, but the IDH1 and 2 IHC was negative. Presumably this is not required?
Interesting. Well, so this person is talking about a tall cell carcinoma with reversed polarity. So those are very characteristic morphologically. So usually the H&E diagnosis is sufficient to make that interpretation. IDH2 immunohistochemistry has been shown to be positive in these cases. I think just a small number of cases have been done at this point in time. So I don't have a great deal of experience with that particular immunohistochemistry. We have been diagnosing them based on the morphology. They are ER, PR, and HER2 negative. Some may show some amount of ER positivity, CK56 positive as well. So, you know, there's other IHC you could use that would help support it, but really the morphology is very characteristic.
Thank you. More questions are coming in. Again, when you need to leave, we understand. Do you use carcinoma of mammary origin in sign out of corneal biopsy to avoid committing to lobular or ductal?
No, we tend to say invasive ductal or invasive lobular carcinoma when we can. Sometimes we say invasive carcinoma with ductal and lobular features if it seems to have features of both. Or sometimes I say invasive carcinoma with predominantly lobular features if I feel like it's probably lobular, but I, you know, don't want to be commit on the core biopsy. We also say in our sign out, we give the size, the grade, the histologic type, and we say in this limited sample. So with that kind of caveat, our clinicians know that any of those factors can change in the excision specimen.
Thank you. I'll point out to everyone that this lecture will be available on YouTube in the near future. I'm getting some questions about that. We will have this available for everyone to listen to again. More questions are coming in. How often do you see smooth muscle metaplasia in the intralobular stroma in benign breast biopsy without fibroadenoma or hamartoma diagnosis, CMB for non-mass enhancement?
Well, so smooth muscle metaplasia you can see in hamartomas and sometimes in fibroadenomas, that's true. I don't know that I've seen it as the only correlate that I've accounted for in a non-mass enhancing lesion. I think I would be careful about that. I'd certainly get levels to see if anything turns up. Other than that, you know, I guess I would be descriptive and have a conversation with a radiologist because I wouldn't be confident that it was the correlate without a more definitive or distinctive mass forming lesion.
Thank you. Next question. If you don't have many tumor cells, like in a cell block, how many cells do you need to be able to report ER?
Well, so I think, you know, I mean, I think you have to do it in conjunction with the morphology of the tumor. So if it is very few tumor cells in a cell block, presumably that I would think is a metastatic sample. So you might want to see what the morphology was of the prior case. The primary tumor, was it ER positive? What does the morphology look like in the cytology specimen that you have? If it looks like it's compatible with ER positivity and you have a few cells that are positive, you know, I would say that it's positive, but maybe I would be just, again, say that this is based on very little material and recommend repeat testing on the excision specimen.
Thank you. The next is a quick follow-up about the TCCRP case. This was not graded by the consultant, but is it considered low grade?
It is considered low grade, yes.
Great, thank you. I'll point out briefly that there are QR codes and URLs available on the screen right now to both claim your CME and offer feedback. You can use those links now. Hopefully the CME is useful and the feedback is much appreciated on our end. A few more questions. What is your recommended use of ecadherin versus P120 in difficult ductal versus lobular cases?
So if you have access to both, I think it's better to use both because P120 is sort of positive. So that's helpful in the lobular lesions. You're not just looking for an absence of something. So we tend to do both. I think, you know, I think people have a lot more experience with ecadherin, so they still like to use that. And even if you can only do ecadherin, you can still interpret lobular lesions that show aberrant expression. It's still possible to recognize that it's aberrant expression because it doesn't look the same as the background ductal epithelium. So you can compare it to the background normal tissue, which would show strong, clean membranous staining, whereas the lobular lesions, it's usually sort of a little splotchy if it does show any staining, and it's not usually clear and distinctive.
Thank you. I've got two more so far. What do you find most helpful in differentiating malignant phylloides tumor from metaplastic carcinoma?
So on core needle biopsy, I would do a panel of keratin stains, and you need to do more than just one keratin stain. So, you know, you could do keratin cocktail, CK56, we do MNF116, keratin 903, and then also I would add in P63 as well. So any of those that show positivity would favor it being metaplastic carcinoma. Beware, though, that malignant phylloides tumors can show focal weak expression of keratin and or P63. So you don't want to, at least on a core needle biopsy, you don't want to totally lock yourself in if it's just focal weak expression with keratin or P63. But both of those require excision, so you know you can be somewhat circumspect and sign it out as a malignant neoplasm, and you can give your differential diagnosis, maybe favor metaplastic carcinoma if there's keratin or P63 staining, and then await the excision.
Great. Next question. So two spaces with ADH are not called DCIS anymore. You only called it DCIS if measurements more than 2 millimeters?
Right. So I'm smiling. You can't see this, but I'm smiling at this question because this is sort of the point that I was trying to emphasize. In a core needle biopsy, I think you need to be very careful in applying the criteria strictly. And that's what the WHO expert panel recommends. They, you know, just two spaces, if you call it DCIS, that patient may go on to have bilateral mastectomies for two spaces of, you know, atypia, low-grade atypia at that. So it's far, far better in the setting of a core needle biopsy and low-grade atypia to call it atypical ductal hyperplasia, or you could say, you know, ADH bordering on low-grade DCIS if you feel more comfortable doing that. But you need to emphasize that it's a borderline lesion on the threshold between ADH and low-grade DCIS. And then when you have the excision specimen, if you have a lot more and it readily meets criteria for DCIS, you can call it low-grade DCIS. So this is, you know, I mean, these criteria are arbitrary as it is. They were defined on excision specimens. So you want to be very careful on core needle biopsy. This comment doesn't apply to intermediate or high-grade DCIS or high-grade epithelial proliferations. Those you should call DCIS, even if they're only small.
Thank you. And the last one I currently have, does the differentiation between ductal and lobular invasive carcinoma have a management impact?
So that doesn't have an impact in our institution. Some people, some clinicians do get MRI studies pre-operatively if you call it lobular carcinoma. So it may have an impact in some institutions, and we certainly hear that when we give talks around the country that, you know, their surgeons want to know whether it's ductal or lobular. But, you know, it's difficult to be categorical about that because, you know, I think you still need to get the entire lesion out. So I guess that would be the only thing, but there are people that would argue against doing preoperative MRI because that, as a routine, because that leads to too much surgery and, you know, more frequent bilateral mastectomies, for instance. So, you know, I guess my answer is sometimes. So there you have it.
All right, that looks like that's it for questions, so I'll cut that off. Thank you again very much, Dr. Collins, for your lecture and for taking the additional time for all this Q&A. Everyone has been saying thank you very much in the chat. So this has been a very successful and wonderful virtual pathology grand rounds. Thank you again.
All right, well, thank you everybody for listening in. Appreciate it.
All right, and briefly, I will announce the next virtual pathology grand rounds will be in July. Dr. Yuri Nikiforov will be speaking on the impact of ThyroSeq molecular testing on diagnosis and management of patients with thyroid nodules and cancer. So again, here are the CME and evaluation links. I'm going to end the session recording now, but I'll leave these up a little longer just in case anyone needs them. Thank you again, everyone, for joining in, and I hope you enjoyed this virtual pathology brain rounds.